This is going to be a very fast-paced but a wonderful semester. So a couple things I want to go over before I get started on lecture. I did give you guys access to the prep work, and so this lecture series, there's going to be 4 parts to it. This lecture series should go along really well with your prep work. So if you've already completed that, you're going to be a little bit ahead of the ball game, because you're going to be able to use this more as highlighting key things that I say, or if there's certain things that you couldn't find when you did open resource. So a little bit about my prep work. I know that for the reproductive stuff, this was a lot of prep work, but reproductive has a lot of weird terminology. So I do apologize. Moving forward, the prep work won't be quite so in-depth, but it's really important for you guys to get all that information, so the prep work will be very, very handy in being able to use it as a study guide. So have your prep work next to you when we do this video. You can fill in any blanks that you have. Also have a sheet of paper or a notebook beside you, so if you are going through it and something doesn't make sense, then we can discuss that in the live Zoom session that we're going to have later on. So please do both of those things so that you can make sure that you get everything that you need out of this. The length of these videos will also be a little bit longer than my traditional recorded lectures, so these may run 30 minutes to an hour versus 20 to 30 minutes just to get all the content in, because it is a lot. And I do understand that this content is a little bit more dry because it's not face-to-face, so it's not as interactive. But I want you to use it to fill in that prep work so that when we get to your live sessions, you will be good to go and have all this information. Your prep work will also serve as a study guide, so that is a little bit relative with nursing, because it's not like I'm going to ask you to recite that information like you might see in other academic classes, but it is the information that you need to know to be able to apply it on a test, because all of your test questions are going to be application. As I go through this, I will try to kind of talk you through a little bit of that so you can see what I mean when I say, well, how do you take that fact and make it an application level question? So I'll try to do that as well. So I guess we'll get started. Here we go. All right, antepartum is going to be the period of time between conception and to the time they go into labor. So this is going to be primarily done, or these patients are primarily going to be seen in the physician's office because it's more of an outpatient kind of thing. So this is the pregnancy part of this lecture. So it does have a lot of information on it, and I do tend to talk pretty fast. So the good thing about having a recording is you can always stop, pause it, and rewind if you need to. But I will try to slow down just a little bit just so you can make sure that you get all the key points that you need to. So here we go. Okay, so for stages of development, a lot of this is just going to be simple terminology that you need to be familiar with, just in case you saw it somewhere. It wouldn't confuse you if, you saw one of these terms. So your pre-embryonic stage is going to be fertilization through the 2nd week. Your embryonic stage is going to be the end of the 2nd week through the end of the 8th week. And then your fetal stage of development is going to be the end of the 8th week until the baby is born. So by far the vast majority of content that we're going to cover is going to be involved in that fetal stage of development of pregnancy. So that's where we'll spend most of our time. Pregnancy is divided into trimesters, which is always a little bit confusing. The first trimester is going to be week 1 through the end of week 13. The second trimester is going to be week 14 through the end of week 27. And your third trimester is going to be the 28 weeks until the end of week 40, or until they deliver, because some patients do go past 40 weeks. So that is how pregnancy is going to be defined. The reason that's kind of important is because sometimes we will mention, or when I'm talking about content, I will say, well, that usually is performed during first trimester or second or third trimester. In addition, there's certain medications that may be safe during third trimester but not safe during first, and vice versa. So it is important that you kind of have a working knowledge of when those trimesters are. So I'm going to go back over those just in case you missed it. So week 1 to week 13 is first trimester. Week 14 through 27 is going to be second trimester. And then week 28 through 40 is going to be third trimester. As far as how often a pregnant patient would come into the physician's office to be assessed, so this is going to be for your normal pregnancy, which is primarily what we're covering this semester. So typically up until 28 weeks gestation, they will come in once a month. So up until 28 weeks gestation, they'll come in once a month. From 28 weeks to 36 weeks, they'll come in every 2 weeks or twice a month. And then from 36 to 40 weeks, they will actually come in every week, because at that point we're anticipating that they're probably going to be going into labor soon, and that's going to require us to keep a little bit closer eye on them. So that's why they're going to be seen more frequently. And again, that is for normal pregnancies. If it's a high-risk pregnancy, or they have twins or triplets, or they're having issues, they may be seen much more frequently than that. So pregnancy has several different milestones. I'm going to be very specific and just give you little tidbits that you need to know for these. So they're listed on your screen. So at 3 weeks, the neural tube develops. So the neural tube is kind of what we would think of as your spinal column, for lack of a better way of putting it. So your neural tube defects that can be seen are spina bifida, which usually affects the lower portion, and then hydrocephalus, which typically affects or will affect the upper portion. So with your neural tube at 3 weeks, most patients don't even realize that they're pregnant, because you're not going to realize that you're pregnant until you miss a menstrual cycle, which is usually going to be 4 to 6 weeks depending on the length of your cycle. So with this, it's very important. It's the reason a lot of your research and stuff will say that you need to be taking prenatal vitamins and supplements prior to thinking about getting pregnant, but that's not always what we see. So at 3 weeks, the neural tube develops. Between 5 and 7 weeks, the fetal heart will start to beat. Now this isn't going to be necessarily where you can, or it's not going to be where you can auscultate it or Doppler it, but if you were to do an ultrasound, you should be able to see a fetal heartbeat by 5 to 7 weeks. So the interesting thing, or the way that you can apply this to a application type question, because you're thinking, well, why do I need to know when the fetal heart rate starts to beat? If you have a patient that comes in and you know they're 9 weeks pregnant, you've got good dates and you know that, and you do not see a fetal heart rate, then we know that pregnancy is not progressing as it should. So it can be a huge red flag. At 10 to 12 weeks, you can actually Doppler the fetal heart rate. So at that point in time, that's when we would be Dopplering that at every office visit when they come in. So at 10 to 12 weeks, you can Doppler a fetal heart rate. And remember, the fetal heart rate is much faster than ours. The normal fetal heart rate is going to be somewhere between 110 and 160. At 13 to 16 weeks, fetal movement may start to be felt, especially if they've had a previous pregnancy and they kind of know what to feel for. The baby will also start to produce, or there will start to be more amniotic fluid produced, and so the baby will start to swallow that, because in utero, that's how one of the mechanisms that babies use to regulate the amount of amniotic fluid that they're swimming around in is to swallow that amniotic fluid. At 17 to 20 weeks, the fetal heart tones can be heard by stethoscope. And by 20 weeks, most patients, or pretty much all patients, should be able to determine that they are having fetal movement. And so just like with you or me, if we get sick, we tend to not want to move around. Well, babies are the same way. And since they can't tell us what's wrong, we have to look for assessment findings that tell us how the baby's doing. So fetal movement is hugely important. So once they start to feel fetal movement, it's very important that they continue to feel that, because sick babies don't move as much, and we would need to be notified if they're not moving at all or not much. At 21 to 24 weeks, the alveoli start to form in the lung, and the lung actually starts to produce surfactant. And surfactant is the stuff that makes it easier for a baby to breathe. It's kind of the lubrication of the lung, so they can take breaths and actually oxygenate their blood. So for this reason, 24 weeks is going to be considered the age of viability. Now, if you look at different resources, you may see that fluctuate down some, closer to 20, 21 weeks. But most of your hospitals, or all your hospitals, governing bodies right now, are still recognizing 24 weeks as the age of viability. So basically what that means for practical reasons is that is when we're going to start getting really aggressive about trying to save a pregnancy or do life-saving measures to make that baby survive. So at 24 weeks, it's not saying that that baby is necessarily going to be born and everything's going to be perfect. It's saying at 24 weeks they have the equipment they need in their lungs to be able to oxygenate their blood. So at that point, with a lot of extra support and a lot of extra help, they could potentially survive outside of mom. At 25 to 28 weeks, the nervous system starts to control many of the body functions. At 29 to 32 weeks, if you did an ultrasound, you would notice that the baby may be practicing breathing. So you'll see rhythmic breathing. Now, obviously in utero, a baby doesn't necessarily, it's not that they're oxygenating with that breathing, but it is practicing getting those muscles ready for the breathing once they get outside of mom. So rhythmic breathing exercises. In utero, what they're breathing in is actually amniotic fluid because the placenta is taking care of the oxygenation for them. I want you to make a note here. It's not going to make really much sense to you right now, but when we talk about how to interpret fetal heart rate strips, it will. So by 32 to 34 weeks, the baby should be able to have enough neurological development or maturity to cause the non-stress test to be reactive. So by 32 to 34 weeks, a baby should have a reactive non-stress test. So just write it down for right now, and then we'll talk about what that actually means when we cover your intrapartum and look at some fetal heart rate strips. At 33 to 38 weeks, the lanugo begins to disappear. So the lanugo is that little fine downy hair that babies have on them, and the closer to term they get, the less little hairs they have on their body. In addition, there's something called vernix, which is the white cheesy stuff. So the more mature the baby is, the less vernix they will have. So this kind of helps us when we are doing gestational age assessments post-delivery to see if that baby really does look like it's the gestational age that we thought it was. So just to kind of give you a little tidbit or frame of reference for this, if you have a premature baby, you would expect them obviously to be smaller, but they would also be more cheesy and have more hair. If you have a post-term or full-term baby, then they're going to have less vernix or less cheesy stuff on them, and they're not going to be as hairy. So it kind of helps us to correlate what we're seeing with what the prenatal record told us that that baby should present as. All right, reproductive organ functions. Some of these are going to be self-explanatory, but other ones, we'll talk a little bit more about. So the uterus is what houses the baby in the placenta and the amniotic sac and the amniotic fluid. It has got to grow exponentially. So when you look at the normal size of the uterus, the typical capacity for a uterus is about 10 milliliters. At the end of pregnancy, it may be 5,000 milliliters or more. So it's a pretty amazing little organ that can adapt and meet the needs of a baby or two, or this day and age, 5 or 6. So it's definitely pretty amazing. A lot of the blood flow in the uterus goes to the placenta because it's doing a lot of the work, which is the next thing on the list. So your placenta, the patient's placenta, is actually kind of everything for the baby. It's what helps to get rid of waste products and CO2. It's what provides nutrients to the baby and oxygenation to the baby. So the placenta is kind of functions as the kidney and the lung of the baby. So it is getting rid of waste products like CO2 and waste products that the kidney would normally, get rid of. And then it's also oxygenating and providing nutrients for the growing fetus. The umbilical cord and Wharton's jelly. There's a lot of weird terminology in your OB stuff, so you're just gonna just bear with me, it's a lot of stuff. But the umbilical cord obviously is what attaches the baby to the placenta, so it's kind of the lifeline of the baby, where the placenta is doing the work. If the cord's not what it should be, then you're also going to have some issues, because the baby can't do what it needs to, or the placenta can't function like it needs to. So the umbilical cord usually has 2 arteries and 1 vein. So I just remember the little acronym AVA, AVA. So it should have 2 arteries and 1 vein. And it should be protected by Wharton's jelly, which kind of looks like pear jelly. It's kind of a weird little color, but it actually provides protection to the umbilical cord so that it doesn't get crimped, or hopefully doesn't get tied in a knot, so it kind of protects the cord from injury. So the umbilical cord, 2 arteries, 1 vein under normal circumstances, with a lot of Wharton's jelly to protect it. Now, a baby can survive if they have 1 artery and 1 vein, but they could not survive if they have 2 arteries, because it would be a closed system. So we do have babies that are born all the time with 1 artery and 1 vein. Those babies they're not usually as big, because they can have some growth restriction, because obviously there's something that's not exactly right in the cord. But 2 arteries and 1 vein is considered normal. When we look at the amniotic sac and the amniotic fluid, so the amniotic sac kind of comes off of the placenta and it surrounds the baby, and then it's filled with amniotic fluid. Very, very, very important. So the amniotic fluid allows the baby to move more freely. It allows symmetrical growth. It helps with thermoregulation. It helps to protect the baby from injury. So the amniotic fluid is very important. But it also tells us a little bit more about what's going on inside as well. So what you may not know is amniotic fluid, a lot of it is made up of baby pee. So if the baby does not have a lot of amniotic fluid, you should consider that there could potentially be an issue with the baby's kidney. If the kidney is not producing enough urine, then obviously the amniotic fluid level is not going to increase like we would expect it to. So the medical term for too little fluid is known as oligohydramnios, because let's just make it as long and difficult as possible. So oligohydramnios means not enough fluid. The most common reason that we see that later on in pregnancy is when the mom's water breaks. Obviously there's not going to be as much fluid around the baby. But if you're looking at this during pregnancy or early pregnancy and they're not having a lot of fluid, that may indicate a problem with the kidney. The term for too much fluid is polyhydramnios. So that means too much. And with polyhydramnios, that could indicate a couple things, or it may be completely benign and not have any bearing on the pregnancy. But a couple things that you would need to kind of keep in mind if you see a patient and they have polyhydramnios is they may have chromosomal abnormalities like Down syndrome. Those type things tend to have more amniotic fluid. So it's not saying they definitely do, but it's something you need to consider. And we mentioned earlier that one way that the baby regulates their amniotic fluid level in utero is to swallow it and let it be processed through their gut. So babies that have a malformation where their esophagus doesn't connect to their stomach can't swallow the amniotic fluid, and they can tend to have high levels of amniotic fluid. So anytime you see low fluid or high fluid, that does need to be investigated to determine what's going on with this pregnancy. Is there a problem? All right, the cervix. The cervix is going to be the bottom part of the uterus, where it actually closes the uterus off. So you can kind of see on the picture there, the uterus is kind of shaped like a light bulb, so it would be the bottom part of the light bulb if you want to think of it that way. The cervix does several different things. It does become very vascular during pregnancy. It's going to soften, but the cervix is actually what produces the mucus plug, which is exactly what it sounds like it is. It's a plug of mucus in the cervix that helps to protect any infection from getting inside the uterus. So the medical term for the mucus plug is the operculum. O-P-E-R-C-U-L-U-M, operculum. So the cervix does also form that or produce that. During pregnancy, that's its main function, is to stay closed and to maintain that mucus plug. During labor, it's also going to be the part that's going to dilate and efface to allow the baby to to pass through the vaginal canal. So cervix is kind of a big deal. All right, breast. The breasts are going to become more vascular. They're going to increase in size, and they're going to have increased pigmentation, so the nipple's going to darken. And all those changes are going to be consistent with preparation for lactation later on when the baby needs that for nutrition. The vagina also goes through some changes as well, so it does have an increased vascularity, so it's going to become more vascular. They may have an increased discharge. The pH of the vaginal area will change, so it makes them higher risk for infections. And then the ovaries are not on here, but the ovaries will stop releasing an egg because obviously there's no need to because one's already been fertilized. All right, changes during pregnancy. So we're going to kind of hit the high points on these because there's a lot of stuff that happens during pregnancy. If you just look at the picture there, you can kind of see how things normally are versus how squished everything is as the baby starts to grow. So a lot of these are kind of going to be self-explanatory as to why you would see these different changes during pregnancy. So with the gastrointestinal system, the patients tend to have increased salivation. There's also an increased risk of gingivitis, and there's a strong link between gingivitis and preterm labor. So it's very important for these patients to make sure they're keeping their dental visits and that we're keeping an eye on that because there's been a very strong link between gum disease or issues with the teeth and preterm labor. They'll also have decreased peristalsis and delayed gastric emptying. So that tends to lead to constipation. Everything's being pushed up, so heartburn or pyrosis is the medical term for that, is very common during pregnancy. And they can also have nausea and vomiting. For your cardiovascular system, the cardiac output is going to increase by somewhere around 40 to 50% during pregnancy. The heart rate usually goes up 10 to 15 beats above their baseline. They'll also have an increase in blood volume. One thing I do want to note with the cardiovascular system are a couple things really. Blood pressure in a pregnant patient should not elevate above their baseline. So whatever they were before they were pregnant, we do not anticipate seeing changes in their blood pressure above whatever their baseline is, which sounds kind of crazy because you have all this extra blood volume on board, but the body compensates by that. There's some vasodilation that occurs. So if they are experiencing elevations in blood pressure above their baseline, that is something that needs to be assessed. And we're not going to cover that this semester so much, but it is something that you'll cover in depth in 211. The other thing that you have to worry about with the cardiovascular system is if you have 50% more blood volume, there are certain patients that may not be able to tolerate that very well. So in addition to the other demands that the pregnancy places on the body, the actual blood volume may be a huge problem. Most of our patients, young and healthy, don't have any underlying health conditions, but if they do, especially if they have cardiovascular disease or a congenital heart defect, those type things can cause this pregnancy to be very high risk and they can have lots of complications. So those patients would be much higher risk for congestive heart failure and those type complications because they can't handle that extra volume. The other patient that this would apply to would be your renal failure patients. So if you had a mom that has a history of renal failure, then she could also have higher risk of fluid retention, pulmonary edema, congestive heart failure. The respiratory system, there's an increased O2 consumption. The diaphragm is most definitely pushed up. The air volume actually does increase as well. And there's some increased vascularity in some of your airways. So it is very common for pregnant patients to complain of nasal congestion. It's also very common for them to have nosebleeds, and epistaxis is going to be your medical term for that. So they may see that. That's not something necessarily in and of itself to worry about. if it could be alarming for different reasons, but just know that some nasal stuffiness and some minor nosebleeds are very common during pregnancy. For the renal and urinary system, there's increased blood flow to the kidneys. The glomerular filtration rate increases by up to 60%. And obviously there's an increase in urination because everything's being squished and the baby likes to kick the bladder, which can cause urination. For the musculoskeletal and integumentary / hair and nails, I'm just going to cover all those together. There is obviously a change in the posture and gait. They kind of get that waddling gait, and that's going to be the body's compensation for the fact that they're very front heavy. The joints will widen and become more movable. So that is in anticipation for labor, so the hip joints and that kind of thing. The feet are also, those joints in the foot also tend to widen, so it's not uncommon for patients to go up about half a shoe size with each pregnancy because of that widening that's seen with the joint changes. The skin may start to have stretch marks, and the medical term for that is striae. They may have a sway back. There's an area of hyperpigmentation that forms. Some people will notice a darkening of on their face or their cheeks, but everybody usually experiences the linea nigra, which is going to be a darkened pigment line down the center of the abdomen. It will go away after pregnancy. Hair loss is not uncommon during pregnancy, so they may have some increased hair loss, but they will also usually have increased nail growth. For the endocrine system, the thyroid function increases, and there's also an insulin demand increase, so the body will also secrete more insulin as well. For the immune changes, a lot of changes that we see with the immune system are kind of keyed in on preventing rejection of that fetus because it can be seen as a foreign body. But the body's way to deal with this does increase the likelihood that they may get infections like urinary tract infections, which also cause some issues with preterm labor. So it's very important that we make sure that we assess these patients for signs of infection, especially UTIs. They don't always get the burning and stinging that we typically see with that, so it becomes something that we check every office visit just to make sure we don't have any underlying infection that they're not having symptoms with. This can also wreak havoc with autoimmune disorders as well, so just kind of keep that in mind also. As far as the emotional impact, there's a lot of different emotions that a patient's going to go through during pregnancy. Ambivalence is usually the first thing that they experience. So ambivalence is kind of a term that just means kind of mixed emotions. Even if this pregnancy was completely planned and they were so super excited about it, when it actually comes to be and they are pregnant, they may have a lot of reservations about being pregnant. The biggest thing is just to make sure they understand that this is a normal feeling and it should pass. Now, obviously, in third trimester, if they're still having mixed feelings, that's a big deal. But it is very common during first trimester and even early second trimester to be a little bit ambivalent about the pregnancy. Patients do tend to become very